So from controversies to consideration, periodic paralysis is a complex topic. Today, Dr. Cannon will be guiding us through those, and so please join me in welcoming Dr. Cannon to the stage for considerations and controversies in periodic paralysis.
Thank you, and I really appreciate this opportunity to share what are my thoughts and experiences, trying to help all of you with a lot of questions that are submitted either through the Ask the Experts on the PPA website, or I monitor what goes on in the Periodic Paralysis Support Network on Facebook. And so the topics I've chosen this morning were sort of based on the flows that I've seen on those social media outlets. And anytime you talk about an area where there are differences of opinions or things that are incompletely resolved, you have to draw upon these three different spheres to try to do your best to provide evidence-based medicine. So it's a consideration, first and foremost, of their patient values and preferences, what they're coming to you with, their problems, telling you about it. You have to be open-minded about that. And then to merge that with relevant scientific evidence, what we know about the biology that might be affecting these processes, and take that into consideration. And then the third sphere being clinical judgment as a practitioner, having seen many patients and delivered healthcare for years. And between the intersection of all of those, the desired outcome is to use an evidence-based medicine approach, and that's what I'm going to try to do for you today as I discuss these topics. So you'll see a whole list there. I'll go through them in order. The first is a consideration of pain or muscle pain, myalgia, as an accompaniment of a muscle ion channelopathy. And I have to pull the medical profession out on the carpet here because many years ago, 10, 20 years ago, there were authoritative articles and book chapters written with statements such as these: pain is not a typical feature of myotonic congenita. Dr. Becker, who was a huge giant in understanding various forms of myotonic congenita, commented that, however, he wondered about a genetic subtype of myotonic congenita with pain, for occasional patients do complain of myalgia. So he thought it was very rare. And another expert said muscle pain is unusual. Only a few patients complain of pain. Well, we know that's very different now. My awareness was expanded by coming to this meeting for many years and hearing you share your stories. And this is very real. There's been a group of neurologists out of Finland. Bjarne Ud is the lead neuromuscular specialist in Finland, who's identified the fact that myalgia in some cases is the predominant symptom for very classic missense mutations in the sodium channel that were initially reported to be a cause for hyperkalemic periodic paralysis and paramyotonic congenita, which is still the case. And those patients may have those symptoms of intermittent weakness and stiffness. But there's a huge family with this A1156T mutation in Finland, over 30 affected individuals. And so they've had lots of opportunity to observe how that impacts patients. And pain, either spontaneous or with muscle exertion, is the predominant symptom here. And interestingly, there are many episodes of pain that can occur without a clinically apparent episode of stiffness, of myotonic stiffness. So they can be dissociated. So again, we have to really broaden our views on how a channelopathy of skeletal muscle might contribute to a myalgia syndrome. And just recently, this same group published a quite amazing paper. So they have, as every neuromuscular practice group has, they have a large group of patients with pain as a primary problem and big fibromyalgia group. But there was one family, you see 3 generations, where what started out with pain on exertion, so rigorous exercise causing pain, over the lifespan became worse to have spontaneous pain even without exertion, and then very severe pain. And later on, they developed a very peculiar wasting of the muscle and then hypertrophy around the shoulder girdle. So clearly something was going on genetically here. And so in screening that family, surprisingly, they found a calcium channel mutation, actually very close to the mutations that cause hypokalemic periodic paralysis. So these patients do not have intermittent paralysis, and they certainly do not have myotonia. There's never been a bona fide case of myotonia caused by a mutation in the calcium channel. So again, it's saying that not all pain is because of involuntary myotonic contractions, and that we really need to be open-minded about the connections that might occur between an ion channelopathy and pain. Now, I'm very happy to, promote the idea that we need to increase our awareness, but I also want to acknowledge that pain is, of course, a very common syndrome, unfortunately, and that there's going to be a huge collection of multiple causes of muscle pain that are not ion channelopathies. So again, don't jump to the conclusion that just because you have significant muscle pain, oh, I must have an ion channelopathy, but this, in some instances, can clearly be the cause. So that's the first point. The second point, I've seen a lot of buzz out there on social media networks about a paper that came out saying that one of these GLP-1 agonists, a semaglutide used for weight loss or diabetes, had enabled a patient with periodic paralysis who had permanent muscle weakness to regain strength. And this is the paper. It came out in a nephrology journal, peer-reviewed journal. And so I took a deep dive looking at this, from the perspective of a neuromuscular lens, and just see if this made sense, and is this an opportunity we need to be aware of. So first of all, this was a single case report, one individual. It's a 48-year-old man. He had classical hyperkalemic periodic paralysis with his attacks beginning at age 4. He'd have about 1 attack per week. At age 30, he began to develop permanent muscle weakness, which is a little bit early, but not unheard of. And he had a very typical mutation of the sodium channel, the T704M. That's probably the most common cause of hyperkalemic periodic paralysis. So there's no question this person had periodic paralysis. That's not an issue. He had tried acetazolamide in the past and even dichlorphenamide for many years and just wasn't really seeing very much benefit. Now, what triggered the events that led to this paper is that clearly he had weight gain. He had a body mass index of 36, which is quite obese. So he's about 260 pounds, a little under 6 feet tall, was having sleep apnea. So for that reason, he was put on a semaglutide for weight loss, typical escalating dose. And the authors put in the paper that he reported that at the time he was getting about 3 attacks per week, referring to the permanent muscle weakness now, but still having the acute attacks that changed from 3 per week to 1 per week. So that's an improvement. That's great. But in the blue text here at the bottom, these are sort of my thoughts on this. So if you have hyperkalemic periodic paralysis, it's biologically reasonable that taking a GLP-1 agonist, which promotes insulin signaling and will promote the movement of potassium into the intracellular muscle space, that could help with the acute attacks. So I don't have a problem with that, and that's something interesting to think about. But you would really like to have seen a record of a diary that was there, or a home monitoring system. All the clinical trials, like the trials for dichlorphenamide in the double-blind crossover trial, all the participants had home reporting devices where they logged in every week and reported their experiences. So again, I'll give them the benefit of a doubt. Maybe there was some improvement, but it wasn't validated in a really robust manner. Where I have more issue is that his permanent weakness, which for him is described in this paper as having difficulty walking. Again, a very reasonable description of permanent muscle weakness that occurs in hyperkalemic periodic paralysis, but they provide this table. It's several tests that are used actually for well-being and mobility, but they're overwhelmingly based on looking at the ability to walk and stand, to get up out of a chair. How quickly do you walk at a normal pace? How quickly do you walk when you're asked to move as quickly as possible? So all of the strength improvements would have benefited from weight loss as well. And when this person was on this medication, he lost 50 pounds. So I think we need to have a fair amount of skepticism that this improved mobility was just from weight loss. The authors recognized that that was a possibility, but they want to dismiss it. I'm not ready to dismiss it. I will tell you that just thinking about the biology of how GLP-1 agonists work and can you make a connection to periodic paralysis, other than the insulin signaling and helping to keep potassium low, I can't think of a direct connection. Again, unfortunately, we know very little about the biology of permanent muscle weakness. We know what it looks like histologically under the microscope. We know how to see it on MRI scans, as Dr. Sutherland said. But because we don't know the biology, it's really not possible to, with any degree of certainty, say whether these GLP-1 agonists should have, a signaling mechanism or some other biological role for improving permanent weakness. So that's my take on that story. So don't rush out or tell your doctor, put me on Ozempic and my permanent muscle weakness will assuredly get better. And, I think there needs to even be caution in people with hypokalemic periodic paralysis because this increased insulin signaling could lower your potassium. And one of the side effects that comes from using these medications is nausea, vomiting, and diarrhea. And just those processes can drive your potassium low. So you would have to be very cautious if you have hypo-PP and want to go on this medication. Okay. I think this is where we're going to want to spend most of our time this morning, which is with genetic testing and how do you deal with ambiguous results and what do these things mean. So let me try to walk you through some of this. The bottom line before getting into the weeds is that, the technology for gene testing is incredibly accurate. And so it's not a question of reading your DNA, it's the interpretation of your results. And there are a lot of powerful tools out there using machine learning, artificial intelligence, trying to understand whether a change in your genetic code would have a consequence on your health. And while those tools are very good, you need to realize those were developed for mutations of any gene. And those software tools were developed to be as generalized as possible. But in the channelopathies of skeletal muscle, you're dealing with a subset of very special gene defects in ion channels expressed in muscle. And so there are additional insights that can be used because of that biology that's going to do a much better job than even these very powerful software tools that are out there to try to understand these variants. So let's talk about this for a little bit. So a variant just means you have a difference between your DNA and a reference map that's sort of a population average that we use for comparisons. And everybody has a lot of variants, thousands of them. You'll see in this paper I'll show you in a few slides, they tried to sort through a case and sequence the whole genome instead of targeted at ion channels. And this one individual had over 50,000 variants. Everybody has tens of thousands of variants. So you can get a sense of the magnitude of the challenge in trying to figure out which ones are significant and which ones are of no consequence. And there can be different types of variants, and this can be important in the context of ion channelopathies of skeletal muscle and trying to ascertain whether your variant might be significant. I'll get to that in a minute when we get specifically to the mutations associated with each of the forms of periodic paralysis. But, a variant could be that one of the letters has just changed. So a single letter or base is called a nucleotide. So a single nucleotide changing, a change or a difference is a polymorphism. So this idea of SNP, single nucleotide polymorphism, means you've just had a single letter that has been changed. Of course, there are many other types of variations that occur out there. You can have a dropout of one or multiple bases, or insertions or duplications. There are all kinds of, every sort of geometrical possible rearrangement that you could imagine essentially has been observed. And so the challenge is to understand how do you interpret these variants? Are they benign? Are they pathogenic or unknown significance? And let me also remind you that the way the genetic code is written, there are little segments, little blocks that are called exons, which are the parts of the instruction that come together and is the blueprint for making something like an ion channel or any other protein in the body. But those blueprints are broken up into little pieces, and there's stuff in between called introns, genetic material, that can allow greater flexibility of swapping in and out these and editing and fine-tuning things. But what that means is if you have a variant in an intron that's not in the part of the instruction that's coding for the protein, that's unlikely to be a cause of a form of periodic paralysis. All the mutations, except for one reported by my friend out of Japan, which caused one of these alternative exons to be put into place. Otherwise, there isn't a single case of mutations in introns or outside the exons that's been associated with definitive cause of periodic paralysis. So again, that's another thing you can use. You might have variants showed up, but they're in non-coding regions of the genome. Okay, so let's talk about the information you get in terms of interpretation of these variants and how you can work with that. So the interpretation provided by the laboratory, like LabCorp or Invitae, is actually very good. They have a lot of experience, and they put a lot of effort in the interpretation of variants. That was their marketing strategy, because everybody was setting up DNA sequencing labs. That's not hard. What's hard is to make sense of the data. And so that's where they made their name. And they did a pretty good job, and they were very conscientious. They've come to us and contacted me, and we've tried to work out and update their database. But it's still an evolving story. You can go to public databases. Many of you probably know about ClinVar and other resources on the internet. And those are very well maintained. They're peer-reviewed, they're self-correcting. But I want to warn you that the so-called annotation, the diseases that they associate with particular variants, are pretty lax. So for example, I know of classical missense mutations that only ever cause hyperkalemic periodic paralysis. And when someone is there annotating that database, they do periodic paralysis, hyperkalemic periodic paralysis, hypokalemic periodic paralysis, thyrotoxic they put every form of periodic paralysis after the list. So be careful. Just because you see it on ClinVar, it's fine to go sleuthing and try to augment the interpretation you've received from the gene testing service, but I just want to warn you that everything needs to be taken into context, and you need to review this material with your healthcare provider. And that's why there are still genetic counselors that work with neurologists, and why this is really important. So let me mention a couple of specific changes that we now know from 30 years of being able to test patients and look at families that have classical presentations and understand what are really rigorous criteria that we can hang our hat on and what's still out there a little bit on the border zone. So probably the easiest, or easy is the wrong term, the form of periodic paralysis for which gene testing, the constraints are very well defined, is hypokalemic periodic paralysis. Because whether it's in the calcium channel or the sodium channel gene, 24 out of 25 mutations are all at a missense mutation coding for a specific type of amino acid called arginine, and in a specific location in the voltage sensor domain of the channel. So if there's a suggestion of hypokalemic periodic paralysis in your family, and gene testing finds a variant that's not at one of these sites, it's very unlikely that that variation is responsible for the symptoms you're experiencing. Again, we stay open-minded, we always look at this, but if you're trying to use a statistical argument, could this be a new cause of hypokalemic paralytic paralysis, well, we would look at it very carefully. So for hypo-PP, knowing something about the biology of the ion channels that cause this disease, you can do much better than these prediction algorithms are going to do in terms of understanding whether there's likely an association here. So for hyperkalemic paralytic paralysis, every well-documented case in which there's a genetic cause has been because of a mutation in the sodium channel gene, SCN4A. And there have been one or two that are small, what are called in-frame deletions, so that you're missing a few amino acids, but the overwhelming majority, and there are over 70 that have been found and verified now, are missense mutations. So you're just substituting one amino acid for another. And not only that, we know that the type of channel defect that will cause hyperkalemic paralytic paralysis or paramyotonia congenita or sodium channel myotonia, all of those cause a change in channel function where there's too much sodium coming through. The channel is open more often than it should be. And we know from 30 years of ion channel biophysics, we know what parts of the channel protein regulate when it opens, when it closes, when it inactivates. And so you can use that information to assist in the interpretation of a variant and where it is. Of course, you might ask, well, what's the gold standard? How do you know when a variant is truly pathogenic and causes a disease? So it's a combination of, using all the available data. So if you have a large family with multiple generations, and this variation appears in all the affected individuals, but none of the unaffected individuals, that's really strong evidence. And that was the basis for some of the first reported mutations. Adding to that, sometimes there are unrelated families that have the same pattern. So if you have more than one family with the same clinical presentation and the same variant, then the data are real, and that's what some of the strongest criteria are that out there in the public databases. In rare instances, you have the ability in the laboratory to test the biological consequence of one of these variations. So that's what our lab did for 15 years. We've probably studied 25 or 30 different mutations in the sodium channel and a couple in the calcium channel. It's a very low throughput laborious system that's driven by curiosity and wanting to understand the disease and to help all of you. So it's not, I actually talked with Invitae of whether they wanted to add the capability of doing functional testing of variants as a way of adding additional information to understand whether they were benign or pathogenic. But that was just a little bit beyond the realm of what was feasible. I will say, with regard to ion channels and lots of variants and testing this, as frustrating as it may seem to you, it's even a bigger puzzle for the epilepsies that are related to ion channel defects. There are many hundreds of them. And so what investigators are doing is using automated robotic electrophysiology platforms that can record from cells. These are multi-million-dollar machines that do everything in an automated way. And one of the challenges is that the defects, the functional defects that we know are sufficient to cause myotonia and periodic paralysis are very subtle. So that creates a real technical challenge for having one of these high throughput automated systems, but it's possible. Anderson-Tawil syndrome is probably the most difficult in terms of sifting through variants and understanding whether something is benign or pathogenic. And the reason is that unlike hypokalemic paralytic paralysis or hyperkalemic paralytic paralysis, where the underlying cause is a change in the channel function. So the mutant channel still has to be operative. It just misbehaves. But in Anderson-Tawil syndrome, this potassium channel is missing. It's not there. And as you can imagine, there are a myriad of ways you could break something so that it doesn't do anything. But there are only very few ways in which you could modify something and it misbehaves, right? So this is much more challenging. And the other thing is you have to begin to consider a lot of regions of the genome that are outside of the coding region that's the instructions to make this channel, because there are a lot of remote segments of DNA that are used to help determine when this gene should be turned on, when should you make more, so regulatory elements that aren't part of making the channel itself. And it's very plausible that disruption of those regulatory elements could cause something like Anderson-Twill. So Anderson-Twill is challenging in that regard. On the other hand, for those of you who are worried about this, the changes in the electrocardiogram are pretty objective, and unlike the challenges with the CMAP long exercise test, the EKG is often a really helpful, objective biomarker of whether somebody has Anderson-Twill. So you've got that advantage, but that's where it is. So now I want to go to the ultra-rare genes that have been associated with periodic paralysis, and they are on the Invitae panel of 6 genes that are sequenced. So probably the biggest elephant in the room is the ryanodine receptor, RYR1. This is the calcium release channel that's inside the cell. It's not actually on the cell surface. It's very well documented that genetic variants in RYR1 can cause important serious muscle disease. There is no question about that. And in fact, this was one of the earliest for malignant hyperthermia. There were pigs with malignant hyperthermia, and it was discovered that they had a problem with calcium release, intracellular calcium release. And once the ryanodine receptor was cloned, the first thing was, let's go look at it in this pig, and sure enough, there were mutations. And there were questions last hour about anesthesia-induced malignant hyperthermia, and most of the risk factors for that go with variants in the RYR1 gene. There are even more cases of muscle disease from RYR1 variants that cause so-called congenital myopathies. This means from birth, you recognize there's a problem with the muscles. So the babies are very floppy. They gain their motor skills on a delayed pattern, so when to roll over, when to sit, when to stand, when to walk. And so this is clearly different from periodic paralysis. There are ryanodine mutation variants that can cause exertional pain and breakdown of muscle, and even rhabdomyolysis, and your urine turns dark brown and you're really breaking down muscle fibers. That's well described. But the challenge is what has happened is there have been a number of families and cases where there's a sort of a background myopathy there that's been there since birth. Some of them are very mild. And then there's been fluctuating episodes of weakness over the course of hours or a day. And so it begins to overlap with periodic paralysis phenotype with the clinical presentation. And so some very outstanding groups, Mike Hanna's group at the University College London is one of the leading neuromuscular centers in the world, investigated several of these cases. And to this day, and I've said this in prior meetings, and it's been 2 years since the last meeting, to this day, there are four well-documented cases in the entire world of an RYR1 variant being a cause of something that overlaps like periodic paralysis that even has to be called atypical periodic paralysis. So it was atypical because the age of onset was later than usual. These individuals were in their 20s or 30s. Another atypical feature is for 3 out of 4 of these cases, the inheritance was recessive pattern, not dominant. All the other forms of periodic paralysis are dominant. So you needed 2 variants to be present for this to occur. So again, I want to remain open-minded, and anybody should give the benefit of the doubt to someone who comes with a problem and you want to try to help them with this. But one of the challenges, the ryanodine receptor is a huge gene. It's 5 times larger than the sodium channel gene. So it's 168,000 nucleotides long. Also, there are big regions of this protein that we don't understand the function of very well yet, and it looks like there's a lot more biological room for variability without changing the function of the channel. When you put those 2 things together, that means that just the statistical likelihood of a variation in the ryanodine receptor gene is huge, much bigger than in the sodium channel gene. So you've got to be really cautious about hanging your hat on a variant of unknown significance in RYR1 as your cause for periodic paralysis. Okay. Another ultra-rare cause of periodic paralysis. This ATP1A2, it's the alpha-2 subunit of the ATP, sodium-potassium ATPase pump. So it's a pump, not a channel. There was a very interesting individual who had seizures since birth, and then later, around age 6, began to have episodes of weakness. The bigger problem actually was the epilepsy. Whole exome sequencing identified a unique variant in this pump, and very interestingly, and why this became a big story, is they did functional, this was Mike Hanna's group in London, they did functional studies of the consequences of this variant, and what it did is it caused the pump to become leaky. So just like leaky channels can cause hypo-BP, this pump became leaky. But this was an extraordinarily rare case. This individual, it was a single new mutation. There's never been another one in the world. You know, Invitae chose to put it on the panel. I don't think you're going to find another one. Another ultra-rare one is this MCM3AP gene, which is a big housekeeping gene for chromosomal processing. There was a Norwegian family with late onset periodic paralysis. So this is a really good story of a genetic cause. There's 3 generations, affected and unaffected. The little red letters down below are showing that all the affected individuals inherited this variant of this gene. This is the case, so it caused a missense mutation where this one individual, the proband that they started with, had 51,000 variants to try to work through. So this is the scope of the challenge, and it was only by, again, being able to do sophisticated bioinformatic studies on unaffected individuals in the same family to hone down on this thing that they identified this variant. But super ultra rare. There might have been 2 additional cases. I say might. One of them was actually from Florida because they were isolated sporadic cases. And so you got to be a little careful about claiming you found the cause of a heritable condition when you've only got a sporadic case. And then there was a report of MT as mitochondrial DNA. So the little powerhouses of your cells that make energy, ATP, the mitochondria, has their own separate set of DNA. So there are a lot of neurologic and neuromuscular diseases caused by mitochondrial DNA defects. And one of them was found in a family where there were episodes of weakness. The caveat on that is that this gene defect is known to very commonly cause something called Charcot-Marie tooth disease, which is a peripheral neuropathy. So to interpret weakness from a muscle problem on top of well-established peripheral neuropathy can sometimes be a problem. So it's unclear whether this is fluctuating motor ability driven by the problem with the nerve versus actually in the muscle. So these are all very rare situations. So another area in gene testing is a lot of individuals are clinically diagnosed, genetically undefined. And that's a legitimate category, okay? And we need to recognize that, and insurance companies recognize that, and people have benefited from Keveyis, and fortunately it's permitted to have special assistance for providing those medications for people even without an identified gene defect, and that's appropriate. But I want you to think about this carefully, where this number came that up to 20% of individuals with bona fide periodic paralysis will not have an identified gene mutation, and therefore we need to keep looking. We just don't know what the gene is yet. So where did this number come from? This was derived from early studies around in the 1990s where research labs were trying to figure out which mutations can cause periodic paralysis. And these were cases where these laboratories, and this was when things like genetic sequencing was very laborious, and so you didn't lightly just jump into the idea of, nowadays, You can take a saliva sample or a blood sample, stick it in a machine, and the next day you get all your sequencing back. This was very laborious. It took a graduate student, 3 months to sequence your gene, okay? So it was very labor intensive. And so they were very selective in terms of which families should be studied, because you wanted to stack the deck with the greatest odds that this was truly an inherited disorder here and not some random spontaneous thing. So most of these cases were multiple affected individuals and multiple generations of families with classical stories of periodic paralysis. Clear trigger factors, responded to the interventions like you would expect. Many of them had abnormal CMAP long exercise test. So everything looking like a textbook case of periodic paralysis, and sometimes a variant was not identified in the 3 classical genes. So that happened. Now it's probably more like about 20% because the screening has, 10% because the screening has become more efficient. But it was in that context that this number came from. So there might be 5,000 individuals in the United States with periodic paralysis. If we be generous and say 20% of them would be in this category of we don't know where the mutation is, that means there might be 1,000 people in the United States with periodic paralysis for whom we haven't been able to identify their mutation. If you look at the statistics on how many individuals go to a physician with a complaint of primary weakness, it's 5% of the population, 17 million people, okay? So there's a math problem there. You've got to be really careful because the number of individuals who have unexplained weakness and their weakness may fluctuate could be huge. Way more than 1,000 people with periodic paralysis. So again, I'm not discounting the fact that there are bona fide cases of periodic paralysis where we can't identify the gene defect yet. And in fact, our lab and at University of California and others, there's the Rare Disease Network, we're trying to help some families figure that out. So it's still there, it's a real thing, but I just want to make all of you aware you can't reach out and grab this 20% number and think, oh, this is just me. You have to be a little bit cautious about that, okay? I had one more topic to do the relation to Ehlers-Danlos. Should I go in? I might go into the break a little bit. Is that okay?
I think that's great. We're going to run over a little bit. We got a long break coming up, so I think a lot of people would like to get some questions.
Probably just 3 minutes or so, okay? And then. Great. All right, so there's a big question about possible overlap with hypermobility Ehlers-Danlos syndrome and whether that clusters with postural orthostatic tachycardia syndrome, POTS, and mast cell activation syndrome, which is like a hypersensitivity allergic reaction. And the question is whether these are comorbidities or in some way related to atypical forms of periodic paralysis. So this goes a little outside of my comfort zone, but I went and did a lot of reading before coming to this meeting. This was an outstanding review article that's in the rheumatology literature, and it was looking at the question of why does there seem to be this clustering of these 3 clinical diagnoses? So hypermobility Ehlers-Danlos, POTS, and mast cell activation syndrome. Why do they travel together and what's going on? And I will tell you that for all of these, it's a clinical diagnosis, meaning there's no one single blood test, there's no one gene test, there's no scan that you can do that can absolutely make the diagnosis for any of these 3. So again, they're real situations, but it requires pulling together a lot of data. And what this article beautifully pointed out is each one of these circles are the symptoms that happen in hypermobility EDS or POTS or mast cell activation syndrome. And the point is there's a huge chunk of overlapping symptoms, that could be with any one of these 3 disorders. And so it's not too surprising that if you have a lot of fatigue, intermittent weakness, maybe abdominal pain, nausea, headaches, you get lightheaded. If you go to a cardiologist, they're going to say you have POTS. If you go to a rheumatologist, they're going to say you have a hereditary Ehlers-Danlos syndrome if you have loose joints and some scarring and skin. If part of this seems to be allergic reactions, your allergist is going to tell you you have MCAS. And it's very, it's a lot of overlap and confusing. And I've highlighted in red that exercise intolerance, fatigue, and weakness are key features of all of these syndromes. And so, I think this is a very real clinical conundrum, but this is not clearly a form of periodic paralysis. So there's never been a variant of an ion channel gene found in any of these three disorders. The weakness that comes associated with these disorders does not clearly have potassium sensitivity, at least in a well-controlled published medical study. There's no history of the compound muscle action potential exercise test abnormality that matches what you would expect in periodic paralysis with this condition. And the interventions that are used for periodic paralysis have not clearly been shown to be beneficial in this situation. So again, I think these can be very important issues to deal with changes in quality of life, with fluctuating muscle strength and problems with fatigue and exercise intolerance. But I think it's probably something other than a form of periodic paralysis. I do just want to end, though, on something that I didn't recognize until coming here to these meetings, which is this very peculiar association with people who have bona fide periodic paralysis with an identified gene defect and have hyperextensible joints. If Jake Levitt were still here, he'd come and put his leg up here and move his wrist back and show you that he has hyperextensible joints. And although there's not a genetic cause for HADS found yet, and that intermittent weakness is not part of the diagnostic criteria of hypermobility EDS, there is this strange thing. So the prevalence of hypermobility EDS is estimated to be about 1 in 3,000. So 30 times more frequent than periodic paralysis. So periodic paralysis gets a smaller dot. So what's surprising is that, so not all hereditary EDS people have periodic paralysis, but when you look at the people inside that red dot who have bona fide ion channel defect identified periodic paralysis, hypermobility is present way more than you would expect by chance. So there's an interesting connection there that I want to stay open-minded about, but I want to be fair to say that if you meet the criteria for a hypermobility EDS, be careful that because your weakness might not be periodic paralysis, you might not respond to the interventions we use in periodic paralysis. So I hope that helps you understand that sometimes the answers aren't black and white, and this is what we do to try to bring some reason to these gray zones. So I'll be happy to take any questions. Thank you very much.
Thank you, Dr. Cannon. All right, so we have the most upvoted question from the app is, I would appreciate hearing some discussion on the taboo subject of the brain-related effects potassium shifts have on mental alertness, sudden mood swings, feelings of depression, or temporary distorted reality.
Yeah, so it's a great question because those three, two of the classical ion channels, the calcium channel and the sodium channel, are expressed in skeletal muscle and not to a significant extent anywhere else, including the brain or peripheral nerve. That said, with acute attacks, which can cause a massive shift of potassium in or out of the muscle cells, which is the major reservoir for the body, there could be changes in serum level potassium that could influence the electrical activity of any excitable tissue, including heart and brain. So you could have secondary effects, not because the channels are there, but because of shifts of electrolytes and things like that. So that's certainly possible. The other interesting thing is that the KCNJ2 channel, the inward rectifier, is in a lot of tissues, including its low expression, but you can detect it in the nervous system as well as bone, heart, and skeletal muscle. So there could be possibilities there. So this is reported very often, and it's something to be aware of. It's not in the initial classical descriptions of periodic paralysis from 50 years ago, but we hear it frequently enough, and it's certainly reasonable that the magnitude of the electrolyte shifts are significant enough that other tissues could be impacted.
All right, thank you for that answer. Another question, very upvoted. People in the same family with the same mutation often have different symptoms, severity, and responses to treatment. Do you see the same phenotype variations in your mouse models, where even with the same mutation, some mice are more severely affected than others, or are your mouse models double mutated homozygous?
So our mouse models, we look at both the heterozygous and the double mutant homozygous, and in either of those, we do see variations from mouse to mouse, from day to day. And in the American quarter horse with periodic paralysis, 5% of all American quarter horses have periodic paralysis. They all have the same sodium channel mutation, and the manifestations are very different. And so this is a very real part of the biology of the disease, and that's because for all of us, your ion channels are being tuned and modified all the time by things like phosphorylation, oxidation, reduction changes, subunits coming up. So the consequence of having a fixed mutation can vary over time and can vary from one individual to another. So that's a well-recognized thing. And just to finish it off, that's why every time we do our preclinical studies of any of these interventions that I mentioned yesterday, we study both hind limb muscles in the mouse, one with the treatment and one without, for that mouse. And each mouse is its internal control because there is this biological variability. So that doesn't exclude, a really important point is that doesn't exclude a diagnosis or mean you don't have a hereditary disease, because not everybody in your family is exactly the same. There can be variation.
Okay, thank you. This one will be a full one. Could the medical team try to explain the link between serum and cellular potassium? How I understand it is that the blood holds about 2% of the total body potassium, with the remainder either in our cells or outside them in balance. Say my potassium level drops to 1.2 millimoles, very low. What's happening? Yes, I'm hypo, but I can also be weak or paralyzed when I have a reading of 3.5 to 4.
Yeah, so first of all, the potassium sensitivity for hypokalemic periodic paralysis and hyperkalemic periodic paralysis is very robust. It's been demonstrated over and over again. But remember, the potassium level sort of sets the stage. And so you're more likely to have an episode of weakness at hypo-PP if your potassium is low. You could have low potassium without having an attack. And you can have an attack when you're in the more of a normal range. So that variability exists. But this person makes a really good point that the overwhelming majority of the potassium in the body is inside cells. And so what that means is, first of all, you can have a radical change, rapid change in the potassium in your blood, so going from 4 down to 3 or 2.5, and in an attack of hypo-PP, it's gone into your muscle cells, but it's not changing the concentration of potassium in your muscle cells very much, because it's a drop in the bucket, because there's so much potassium inside the cell and the volume of the cells is larger. So it's actually a big biological problem that we learn to deal with evolutionarily, which is when you do a lot of vigorous exercise and so forth, a lot of potassium comes out of your muscle and your body has to deal with it. And so that's why it has compensatory responses like ramping up pumps, dumping potassium into the urine, and things like that. So it is a delicate balance, and this person is absolutely right. With regard to potassium, there can be very large fluctuations in the blood potassium level, large meaning just 1 or 2 milliequivalents, which at a ratio ways is large, without much changing inside the cell because of the volumes of the 2 different compartments.
Okay. This question is, I know that a lot of people have had a bad experience being wrongly diagnosed with FND, which is functional neurological disorder, and that FND has often been wrongly seen as all in your head or even faking it. However, recent research shows FND is a legitimate disorder of the brain-body connection. I've been diagnosed with both PP and FND. I'm curious, is this common?
So it's very common for physicians to use the so-called diagnosis of exclusion pathway. So someone comes in with a problem. Sometimes it can be difficult to document because it's episodic and you're not symptomatic at the doctor's office. Sometimes it's a perception or a sensory or behavioral thing for which it's harder to get a biomarker for. And so In puzzling cases that don't all fit together, then things fall into categories like, fibromyalgia, functional neurologic disorder, and so forth. And I'm sure there are many people in the room here, probably everybody in the room, who's experienced those kinds of labels in their journey to eventually get a correct diagnosis. So unfortunately, that still happens very frequently, and it kind of relates back to Jake's story of when you hear hoofbeats, think horses. Because if you're just to look statistically at this large collection of people with symptoms that are hard to tag to a specific medical condition, it's a huge number of people. And all those people don't, if weakness is their unexplained symptom, all those people surely don't have periodic paralysis. And how you hone in on that is a huge challenge. And unfortunately, because the testing still isn't perfect, it's still a long journey. It's come a long way with easier accessibility to gene testing, follow up with a CMAP exercise test if necessary. But this is going to be a challenge that we're chipping away at, but we'll be there, for the foreseeable future.
Okay, thank you. And we'll do a couple more before we take the break, and then if anybody has one in the room, I'm super glad. Yep, I'll come get you. Does normocalemic periodic paralysis actually exist? I've heard mixed reports on this.
I'm glad somebody asked that question. So there was a big famous paper describing a family that had these attacks of paralysis, and when they tried to catch the blood level during an attack, they couldn't find any differences. And they wrote this up as a big new form of periodic paralysis. And for the data available, that was the appropriate thing to do. This was way before gene testing was available. Once testing was available and that family was examined over more and more years, because there's some very famous large families that have been studied at academic medical centers, their attacks begin to look more like hyperkalemic periodic paralysis, and they had the T704M mutation. So what this illustrates is that all of you know, even with bona fide hypo or hyperkalemic periodic paralysis, there are many, many times where in the emergency room, your potassium is going to be normal, and that's what happened with his family. I will say that it's the overwhelming majority of families that had previously been characterized as normocalemic periodic paralysis with, clear family history and all the other classic symptoms turned out to have hyperkalemic periodic paralysis for the majority, because myotonia often accompanied that, and when myotonia is present, that takes you out of the hypo-PP category and shifts it more towards that. But what's you need to be cautious about is somebody saying, I'm clinically diagnosed, but there's no genetic cause, and my potassium has never been abnormal, so I have normocalemic periodic paralysis. That's a dangerous set of assumptions to tie together.
That kind of leads into my question. So someone who displays as hyper but is undefined, what do you suggest as next steps for research and treatment?
Yeah. So when you say as hyper, meaning that if you eat carbohydrates, it helps you. If you fast, it's bad. You might have myotonic stiffness or things like that, but no gene defect. So first of all, if you have all of those features, I think the recommendations for management of hyperkalemic periodic paralysis are the best plan to follow, first of all. So even in the absence of an identified defect, when it's clear cut like that, yes, by all means follow the recommendations. Again, for hyper, really the lifestyle changes and eating carbohydrates helps a lot of people. The albuterol is pretty easy to do. If you're going to escalate up to carbonic anhydrase inhibitors, then you really have to look at the cost-benefit ratio for you. We haven't said this, but with every single carbonic anhydrase inhibitor that's ever been used, you have about a 7-fold increased risk of developing kidney stones. So if you're on a carbonic anhydrase inhibitor persistently, you should have an annual ultrasound to make sure you're not developing a kidney stone. But I think it's fine to conduct yourself and follow the recommendations for hyperkalemic periodic paralysis in that case.
Thank you very much. And as you all get ready, when we come back on break, we'll do an Ask the Expert. And so if you have specific questions, this is actually a great time to do that. And it's such a good experience. So you'll have a little bit of time to prep. Question, and we'll do a couple more minutes if it's okay with you. Are tonic movements sometimes seen before or during paralysis attacks?
Yeah, so you have to be careful with the words, tonic movements. So in medicine, tonic usually means sustained rather than intermittent. However, muscle tone is the resistance to passive movement, which is when it's abnormally elevated, that's classically an upper motor neuron, so a nerve problem, not a muscle problem. So you've got to be really careful, but I'll interpret this to say people have abnormal movements before or after episodes of weakness. And again, I've been educated by interacting with this community to say that I've seen them, and yes, it can happen. However, the classical appearance of myotonia is an involuntary after contraction. So you've done a voluntary contraction first and then can't let go, whereas myotonia doesn't typically occur spontaneously. Now, it can be triggered by percussion of the muscle, so tapping or moving a limb and readjusting could trigger it, but myotonia is usually not a spontaneous event. But clearly this can happen. You've all probably seen the videos that Monica was kind enough to share, which is a good example. So yes, you can see it, and it does make sense with the transitions and excitability that are going on with muscle.
Okay, very good. I'll do a couple more quick ones and then we'll go to break. How do I keep up with the news on, and I'm not familiar with it, XEN 1101?
Yeah.
And where can I get it after it comes out, and can I be part of the clinical trials?
Yeah. So XEN 1101, which is from Xenon Pharmaceuticals, which is the new anti-epilepsy drug, that's what it's being marketed as. I don't know exactly when it's going to be available. It got past phase 2B trial. If you Google XEN 1101, you'll sort of see the updates and the news available for them. Interestingly, I asked the company if they wanted to sponsor our work, and they didn't see the reason to do that, but maybe they will soon. And but I think once the data I showed you actually is under review now at a journal. And once that comes out, I'm hoping that will inspire a lot of our colleagues who do clinical-based, patient-based studies will be motivated to do this.
Very good. Are there any scientific links to allergic reactions causing hypo-PP episodes? I know anecdotally there are a number of people who experience this.
Yes, not that I'm aware of. So these ion channels are not in the immune cells that trigger acute allergic reactions, and so I'd have trouble connecting the dots there.
Is there a way for patients or families to submit VUSs to a database to try to add to the research discussions, or could applications such as Epic Cosmos help with data mining?
Yeah, so these databases try to be adaptive and self-correcting, and they've reached out to some experts, including myself, to update the annotation. Anyone who's having trouble with the VUS, if they submit the information through the Ask the Experts in the PPA, I'll be happy to help you with it.
Okay, and I think we're running up on time, so please a round of applause for Dr. Cannon.
Thank you.